Hi, Dr. Brian Hoffman, a family doctor turned patient with CLL the last day of ASH 2013 in New Orleans. And Dr. Byrd, you want to introduce yourself?
Yeah, hi, I'm Dr. John Byrd. I'm a professor of medicine and medicinal chemistry and director of the Division of Hematology at the Ohio State University Comprehensive Cancer Center.
So we've been talking about some of the second generation medications, or maybe even third generations, that are coming up, some of the new oral meds and why those are important. And there's a couple other things that have caught your attention here that you wanted to share with us.
Yeah, well, two things. The long-term follow-up of the Ibrutinib studies was presented here. And Susan O'Brien presented a poster yesterday, and I find it continually encouraging that the progression-free survival for both the untreated patients and the previously treated patients, as we continue to follow them. Very few patients are relapsing. We are seeing a few patients that relapse, mostly the 17Ps, and that's something that we're continuing to watch. But it's sort of emphasizing the durability of Ibrutinib right now, and also that we're not seeing late side effects, which is
we're seeing less side effects,
which is important. Yeah, which is exciting. And actually we're seeing people's immunoglobulins start to go up, and some evidence that we're seeing normal immune reconstitution in these patients. And so,
aren't the T cell populations changing a little bit in a more positive way?
In some patients, they are. Yeah. So it's really exciting, and so that was exciting. And then, say at the plenary session, there was a new antibody that it's called Obinutuzumub, or GA101, and study that this CLL11 study added this to chlorambucil and compared it to rituximab and chlorambucil versus chlorambucil alone. And it was not surprising that the Obinutuzumab and the rituximab both added to chlorambucil. We all knew that was going to happen.
Yeah.
That's sort of beating up on the small kid in the playground.
Yeah.
But I think I was really excited about the Obinutuzumab chlorambucil because it showed a survival advantage in patients with slow go, so patients that are generally older that can't tolerate aggressive chemotherapy. And there's not been any therapy thus far in the field of CLL that's been shown to prolong survival. Now, the question is, in real practice, is to say, can you just give Obinutuzumab and not give the chlorambucil? And that's been the sputtering behind the scenes. Obinutuzumab for a patient has more infusion side effects, and so it's important for patients to realize if they're getting this, because as we've talked many times, the best patient is one that's educated about everything that's being done. That Obinutuzumab tends to cause infusion side effects during the first 30 minutes, sometimes during the first minute of the infusion, which is different than rituximab and other antibodies that cause infusion side effects. At the 2-hour, generally about the 2-hour time point. And so you have to be ready and aware for that. And for some patients, the reactions with this antibody can be more severe than you see with rituximab. But generally, after the first infusion, this is an easy antibody to give. And as I said, it prolongs survival. So it's going to be. I see it for most patients. For most patients in this patient group, getting chemoimmunotherapy, if they're getting that this is probably going to be a replacement for rituximab.
And there were some complete remissions, which we rarely see.
Absolutely.
With rituximab.
There's another abstract comparing chlorambucil, again, beating up on chlorambucil versus chlorambucil ofatumumab, which again showed an improvement in progression-free survival. That was a smaller study, and it wasn't designed to show an overall survival advantage. And one did emerge, and so I think both are good antibodies. They're improved over rituximab, and it's just exciting that we have all these active drugs available for our patients now.
Am I right in understanding that I see a correlation between the more potent the monoclonal antibody is, the more risk of the infusion reaction? Is that, the higher kill rate, is that too simplistic, or is that?
No, it's actually right on the money, and we think that both the NK cell activation, which Obinutuzumab does better,
and the natural killer, yeah,
right,
yeah.
and the complement activation that ofatumumab does, both contribute to infusion side effects, and they both have more than rituximab, and you probably see more infusion toxicities with both of them. But they're better, they're better antibodies, and as long as you're getting treated by somebody who's experienced with managing the side effects, say, and you're cautious, you give a small dose at the beginning, and you watch the patient closely. Say patients can get through this. There are a few patients that have problems where you have to stop the therapy and not give it, but the majority can get through it, and it makes a difference because, as I said, people are surviving longer, and that was the first time that's ever been shown for this patient population.
So remind me, because I get this mixed up, and maybe I have the nomenclature wrong. Type 1 and type 2 monoclonal antibodies. Can you?
Yeah. So type 1 antibodies don't directly kill, whereas type 2 antibodies directly kill. You don't have to cross-link them.
So rituximab is a type 1, and obinutuzumab is a type 2.
And ofatumumab is a type 1, although it mediates better complement than obinutuzumab. So generally, antibodies that are type 2 directly kill, antibodies that are but don't mediate good complement, and antibodies that are type 1 mediate good complement but don't directly kill.
And when something's glycoengineered, which seems to be a big buzz,
right?
What does that mean exactly?
Essentially, it essentially means you've put flypaper on the table. So if the fly gets real close to it, they're gonna get stuck. And so if you think of the antibody and the antibody sitting on the cell, the immune cells floating around, if they get close to it, it attracts them to it better, and they bind and kill the tumor cells better based upon that. And it's a real neat technology. There are two technologies really, the glycoengineering, and also you can engineer the Fc receptor to improve the binding of the immune cells, and both of those technologies appear to work very well for antibodies and CLL.
Any final thoughts or anything else from ASH this year that you wanted to share?
This has been a real exciting meeting. We're seeing many of these new drugs coming forward. We're hearing about very, very durable remissions, and it's going to be fun, I think, over the next several years to see, hopefully, in the great majority of patients, the death of chemotherapy, and us moving on to targeted treatments.
Good. All right.
All right,
Thanks
great.
so much.
Thank you. Yep.